One of the things that struck me, that y'all increased my awareness in the conversation, was all of your experiences with partnerships in clinical trials. Um, how can we do a better job of involving stakeholders? And then one of the things that Alicia and Deborah and Patty highlighted for me this morning is, from whose perception is the stakeholder? Is it the patient's, or is it the provider's perception of who the players are? Also, Giovanni, I hate the word stakeholder. It's jargon. It doesn't sound personal. So, but the question is this: how can we do a better job of like identifying who needs to be informed, and when and how to inform them? So that's my first question.
I can start. Um, so I think stakeholders in general, the term is very broad. And I think oftentimes we do get in a situation where we're working in silos and we don't kind of come up and see who else is working in our space. But I think it's very important to bring those non-traditional partners into our space. So when we start thinking about the importance of health literacy and clinical trials and health in general, who are some of those non-traditional partners? So so looking at health in all policy. So from my perspective, being a public health agency, so looking at education, Department of Education, looking at transportation, so looking at housing, for example. So those are three non-traditional sectors that health folks normally don't think about including, but their policies have a significant impact on how people operate. So for example, if you're looking at transportation, how does the person get to the clinical trial? Is their neighborhood safe enough for them to either get on public transportation? Do they have access to their own car, for example? When you're thinking about housing, do they have safe housing? So when you're thinking about a person embarking on something else, you need to make sure that all the other areas of their life are intact so they can, because people are going to prioritize what they have to make decisions about. And so you don't want their health to fall at the bottom of the totem pole because there's a more pressing issue like safe housing ahead of them. So working with those different sectors to make sure that we're looking at this holistic approach to health and bringing all those stakeholders to the table so we can have common conversations and not just breaking off into our own silos.
So in developing a clinical trial, some of these people need to be involved in the design of it. I know transportation is huge, but what do the rest of y'all think about casting a net? How do you figure out who's in that net? Yeah.
Yeah, so I'll just speak from my perspective working in pharma, is that, when before we even embark on clinical trials, on a clinical trial, we start with the unmet medical need. What is the unmet medical need? And once we've identified that unmet medical need, then we look at who are the patients and where are they and how do they live in their communities. And then what we do actually have a patient advocacy group that then will look and say, within that patient population, who are the influencers? I mean, it's not just healthcare professionals. Are there faith-based leaders? Are there educators, teachers? Who are the other influencers that really influence this patient population? And what we do is that we make sure we make sure that our patient advocacy group colleagues make sure our scientists and our researchers are getting those insights from those influencers and implementing them into a clinical trial design or whatever that may be. So I just really would challenge us to think that it's not just healthcare professionals, it's not just clinical research investigators. Where do the patients live? What are their communities like? And who are the other influences? And they should be included as well. Because when we say, for example, people today still do not know what a clinical trial is.
Well, it's jargon.
Yeah. So then who are the other people who influence the communities about information? It's educators. It's faith-based leaders. It's community organizers. Do those people have information about clinical trials? So that's really, a question, and something I challenge all of us to think more broadly about who we're trying to target with this.
Becky or Monica, do y'all have a comment?
Yeah, I can comment about involving people. So, for example, Dr. McKee and I, we have an NIH R01 on perinatal health of women who are deaf and hard of hearing. And so the importance of inclusion there, so we have investigators and co-investigators who are deaf and hard of hearing. We have research staff who are deaf and hard of hearing. We have advisory board members who represent the community. We also involve the large organizations that represent the National Association of the Deaf. So we're in every possible sort of sphere that inclusion is involved.
Have people that you're trying to reach also.
Yeah,
Deaf and hard
yeah.
of hearing researchers.
Absolutely, absolutely. And I also had another R01 on women with physical disabilities. Two of my co-investigators were women with physical disabilities. One was a clinician, one was a health services researcher. We had, and it was the same thing, you know, across the board. And so when we were, you know, part of it was these large, you know, looking at large data, but part of it was, it's a mixed method study. We were interviewing women. And it was the co-investigators with physical disabilities, with lived experience, were interviewing women. And so it just becomes so much more powerful. The data that you retrieve from that and the entire study is that much more powerful. You know, and I can say that for pretty much every study I'm involved in. So it's critically important for us.
Maybe you're passionate about the quality of trials. How do you think this involvement enhances the quality?
Yeah, I think there's kind of two aspects of quality. One is, you know, the quality of the information itself. Can you understand, you know, what it is that's being done? But then there's actually the quality of the design of the trial, which is a whole different, you know, kind of can of worms. And I think one of the challenges that we have in this space is that when we talk about clinical trials, we do talk about them as if they all are sort of equal. And unfortunately, that's not the case. Not all clinical trials are equal. And when it comes to any individual's, you know, preferences and what's important to them, that's really going to vary when making decisions. And so a lot of it has to do more with how do you help someone understand the questions that may be important to ask in the context of a clinical trial to help tease out those things that are important to them. But there's a wide range in that quality question.
Let me throw you one other question in your role. If you're an investigator, you write for a pot of money. So you're trying to please those people too, so you can get the funding. But it's important to include all these other people. You have any comments about that balance of increasingly the feds want inclusion of stakeholders and patients, but it's challenging to do that preliminary research without money or in just hopes that the clinical trial is going to be awarded one of these days.
I guess I'm not quite sure how to answer that question. Could you target it a little bit more?
Well, when we cast, sometimes I get overwhelmed when we cast a broad net and then thinking of the how-tos, how you're going to do that where, and come in on budget and on time. And we were talking this morning about time. Time in some ways is an enemy to being inclusive, as inclusive as we've realized this morning we need to be. I just think that's challenging.
There are a lot of eager people to answer this part of it. And I think, you know, one of the things that we had discussed in our pre-call was this aspect of resources. It's frequently used as maybe an excuse around the ability to not deliver on a quality issue. And I think that really needs to be flipped to really consider what resources you need to deliver a quality trial, and that's how it should be designed, not the other way around.
So I think it's important to, I'm going to use the phrase, bake it in. So we, you know, thinking about what we did 10 years ago and 20 years ago, it was always the issue of resources and how do we include communities of color and how do we do this? And every time we rise to the challenge, right? We do what we have to do. And I think, so in my research shop, we have our funding is from NIH and NIDLR, which is the National Institute of Disability, Independent Living and Rehabilitation Research down the road here. And NIDLR has very clear expectations. You have to involve communities. You cannot, we will not get $1 from NIDLR if you don't. NIH, frankly, doesn't have the same level of need for community involvement. However, it doesn't matter which grant I write, I use the same principles. To me, that is fundamental.
Bake it in.
I bake, so whatever I'm doing, it is, so in many ways, the two grants, in terms of inclusion, don't look very different, even the grantors have very different needs.
Question about communication. We were talking about messaging. And one of the questions I asked on the phone call was, when we're talking about including minorities and people with disabilities, tell me about the pictures to use. Because I never knew, sometimes those pictures like Precision Medicine Initiative, it looks like they got a picture of every race and ethnicity and somebody in a wheelchair. And I'm thinking, is this effective or not? I don't know. What do y'all think about the pictures and the message, the context we were talking about? Talk to me about messaging.
Maybe I can start. I think it's important when we say that we really have to involve the communities and the patients at every step of development. And part of it is really testing the materials. So we need feedback. We might think we know what, we might want to know, we think we get it, but actually sometimes we actually miss it. And getting insights from the communities we're trying to reach is really key. So really to me, it's making sure that we always say patients at the center of everything. Patients, communities, the influencers are all involved at every step. I think is really important to really drive up quality and everything. And I think also another thing is really when we talk about empowering the patient, I really think patients need to understand that really we might be here sit and talk all day about clinical trials. Clinical trials would never happen without patients. So really they're at the key of everything. And do they really understand the important role they have to play in helping us bring breakthrough medicines to market?
One of the things in our focus group, the clinical research associates tell patients, none of the treatments we have for cancer now would be available without the volunteer participation of people who've come before you. And so that's a powerful, powerful message. Some of the rest of y'all about messaging. I know people in rural areas have told me some of the messaging that's we have in urban areas don't land right on them. Y'all have any other comments, lessons learned on pictures or words or context? Or
I just have one thing to say, that just pictures is tokenism. So we have to remember that. Just placing a picture, for example, for, most of my work is, all my work is on people with disabilities. It cannot just start and stop at those brochures or website pictures. And plus with disabilities, there's a lot of, we also only go to the websites where there are not models with disabilities, like a able-bodied person in a wheelchair. I'm just putting that in because that's another part of it. But essentially, it cannot just stop at messaging.
I think pictures of real people convey authenticity. You can tell they're not models, and that's pleasing in some ways. What about you, Giovanni?
So I would just echo what Emma has already said about the message testing. So when you were asking about, what is working, what's not working, that's one of the things that we do when we develop, let's say, a fact sheet that has a graphic on it, for example. We'll reach out to our stakeholders and say, hey, what is this image, what is this message conveying to you using this image? And sometimes we have missed the mark in the planning phase where, let's say we're talking about asthma, for example, and we have a picture of a bunch of different asthma treatments. Well, some people will come back and say, well, what is that right there? We don't know what that is. We're like, oh, well, that's a nebulizer. They're like, oh, well, to me, it didn't really look like that. Or if we have a picture of a diverse group of people, to your point, having one of everybody in the picture, does that really resonate with the audience, or should you scale it back and maybe, have, one group of people, which is why we go through the process of making sure that we do have the materials tailored for each of the groups that we're trying to message towards. So we have those individualized graphics and images. And, you know, sometimes when you look at infographics, for example, you may want to take more of a, like an animated approach. So it's not actually a human person in the picture, but it's animated graphics depicting, you know, a process or some steps to take to do X, Y, and Z, for example. So I think it really goes back to the message testing and also deciding which strategy works best for which type of communication. The same graphics you use on a fact sheet may not resonate well on social media or may not resonate well in a video. It may not, you know, capture that same essence of the message. So I think it goes back to the beginning, asking the questions up front, involving community members, whoever you're trying to message towards, getting them involved in the conversation early on.
I gave you an example of that. One of the coolest things I saw is developed by pediatricians in Wisconsin who were GI docs, and they had an animated cartoon of a kid getting a colonoscopy, and he narrates it. And then it's not him who gets the colonoscopy, it's the teddy bear. And so it's not scary, and it's the kid's voice throughout. And so it lands well with the audience that they're looking at. So here's my final question. If there's one thing you could change, if you want the Health Literacy Roundtable to move the needle, what's one or two things you think are key to moving the needle? You need a day to think about it?
I know. Wow. To me, really, the message needs to get out there that it's not just who we think that, I know you don't like this word, Terry, stakeholders are. It's more than that. It's not just your physician. It's not just your clinical research investigator. It's a lot more. We need to do a better job educating people about what clinical trials are. I mean, it's 2019, and clinical trials are still, people are like, what are you talking about? Is that me going into a lab, and what are you going to do to me? I mean, that should be something that becomes sort of like common knowledge, because really it affects all of us. One day we'll all be patients. One day we'll all need breakthrough medicines that, you know, help improve our lives. So really, to me, I really want people to know that it takes a village. It takes a village to conduct clinical trials, and we all should be concerned about it.
I think it's important to build trust. It's important to look at who's not at the table, and as I said, inclusion.
So I would say, looking at the terminology that we're using, I think as scientists and researchers, we get stuck in the jargon, and I don't think some of these terms are as relevant as they were maybe 10, 20 years ago. Some of them are very scary, they're intimidating, so maybe we need to start adjusting our language to adapt to the changing needs of our populations. And I would say, also to add to what the other panelists have said, is being creative in how we get the information out there. You know, getting outside of this one-size-fits-all approach is going to work for everybody. I realize resources are limited, but we need to be creative with how we're using those resources to make sure that we're getting the message out so we can do things like build trust, get more people at the table, for example.
Yeah, and I think I maybe made my wish in my opening talk, but I think that really kind of focusing again at the very beginning on how we intend to communicate about the trial and recognizing that it starts with that initial documentation and really trying to re-envision and prepare people for how that information can be leveraged in all of these different sources, and having that start at the very beginning and kind of building it into that process rather than trying to think of it as an accessory or another part of the process, really integrating it.
See if I got it right. Increase awareness of everybody about clinical trials and their importance. Increase trust. Increase useful language that resonates with people. Maybe new approaches. And then Becky, is this clear language from the get-go, but it's like the purpose of what you're doing needs to be clear and easily recalled. Why are you doing this? When you say from the get-go, tell me exactly what you mean.
Yeah, so I think, where I sit, I'm looking at, a very narrow aspect of this whole process. And so from where I sit, I see people relying on this single document to be communicating information about a specific clinical trial. And that document right now isn't fully serving all of the needs that have been discussed during this workshop today. So it's about thinking, if that is the document, the source of truth about a clinical trial, how can we optimize that to ensure that it's going to meet all of these other needs, and thinking about, what kind of appendices, if you will, might need to accompany it to ensure that it's part of the entire clinical trial process, not just a document.
That's a big document, it needs to be good.
Yes.
It needs to be useful and not a.
For all of its purposes that were never initially intentioned, but that's where we are today.
So put up your cards, Chris.
This is a follow-up for Dr. Williams. Now, a couple of questions. I think we've talked about this, but just for everybody to hear, what are the current user stats? Who's using CT.gov? And then the second question is, what do you wish researchers would kind of, the data that's there already, what do you think we can learn from that if we only, sought to try?
So one of the things that I think is amazing about the resource of clinicaltrials.gov is it's used by any type of individual that you can imagine. But in general, it's about half of our users are who you might classify as patients or the public, and the other half is kind of researchers, healthcare providers, information professionals like librarians within that category. And I think that's given the broad range of interests in the information that we have, that creates some really amazing challenges in terms of how to make that information as useful as possible to as many of those audience so they can extract the value that was really intended by all of the various policies and laws that we have reinforcing it. And I think the second part of your question
Have
was.
researchers been kind of mining the data that's there to kind of,
Yeah.
to improve the process, improve how they do things, or have you not seen that?
Yeah, so I think, again, what's amazing is that we don't have to come up with all the ideas ourselves. That's the beauty of making data available, is that other people are able to kind of innovate off of it and learn from it. As I mentioned kind of in the beginning, we do have an amazing opportunity right now with the expansion of making available the informed consent forms. It is really going to serve as a rich source for research. I think we've also seen, many other uses. There's some amazing patient navigator services that are run by different sort of patient advocacy organizations that support patients in using the site and understanding some of the information that's really targeted at their specific disease. That's something that, we can't deliver broadly at the National Library of Medicine in terms of serving every very specific patient audience. But again, by making that data available, others are able to fill in those gaps where they really see a need to be able to leverage and use that content.
This is Jennifer Dillahay. It has to do with the quality of trials, and your discussion reminded me of an article I read years ago when I was being trained in infectious diseases. It was a study of patient adherence in the early clinical trials of the HIV medications. So obviously, if patient adherence was off in the trials, it would throw the results. And what they found was that the factor that was most predictive of patient adherence was whether or not the patients perceived that the people in the clinic cared about them. And that was before I ever heard of the term health literacy. But in reflecting on that, I wonder if perhaps the reason the patients perceived that the people in the clinic cared about them was because the people in the clinic used health literate practices to make sure the patients knew what they understood, knew what was going on, that they understood, and had their needs met in terms of informed consent and understanding and so forth. So it just, your discussion heightened today for me the need for including health literacy to actually get accurate results for any clinical trial. That because patients won't adhere to the protocols and they won't tell the researchers they're not, and then our trials are thrown. So any comments or questions or thoughts about that?
Okay, so this is just something I've been thinking about. I'm Vanessa Simons. This is something I've been thinking about today. How can we hold researchers accountable, researchers who don't have a background in health literacy or health communication? I think you guys talked about funders, but I was also wondering about, are there policies or practices that IRBs should be enacting right now, or is there anyone else that should be at the table, the stakeholder, what they can do?
This is definitely outside of my area of expertise, but I think it is an area of discussion in general around sort of what are the competencies that investigators and other research team personnel should have. And I know there's been many kind of looks at some of that, but I'm sure other people in the audience might actually know more about those particular initiatives than I do, but I think it's an important question.
No, it drives me crazy when some of the investigators I'm working with, their communications are not their highest skill.
So my question, it kind of stems from what you were saying about from past to future, but the question's kind of more directed toward Giovanni, and just thinking about, so research has such, and all of you really, in terms of addressing this topic, but so research does have a dark history, especially within our country, and there's a legacy there. And so what I'm wondering is, do those conversations come up when we're working with certain communities? And how is that addressed? And is that something that the researchers are taking from a proactive standpoint in order to gain the trust, potentially increase our adherence, make sure we have this relationship where we can do all of these best practices that we're discussing? But does that conversation come up? And if so, how is it dealt with? And not does it come up, who is initiating that conversation?
So when you're talking about the dark history of research, so that's one of the things that we were trying to address with our clinical trials campaign. But when we were looking at the research, what we were finding is that's becoming less and less of an issue. The real issue that's becoming more prevalent is people actually just being asked. The number one reason why people aren't engaging in clinical research is because they were not asked to do so. They didn't even know that there was a clinical trial available. They didn't know what is it. To your point, they didn't even know what a clinical trial was. So I think the conversation needs to start there. And then how do we figure out how to bridge the gap between the patient and the medical provider? You made a good point about engaging community members, for example, faith-based people. Also looking at who are the gatekeepers of the community. Those are the people you need to start talking with so you can build that trust. And so if those conversations do come up, they're equipped to handle it. And so therefore the patient can better communicate with their medical provider. So yes, the medical provider should be talking to their patients about clinical trials, but we also should be making the information available for consumers to be able to make those decisions on their own and to be able to go to their provider to say, hey, I read about this, I want more information. So I think it really starts with just starting the conversation, just asking them to be involved in clinical research.
May I just follow up with one question? And I had heard similarly from a research standpoint, none that I did, but that, again, it's more of a question of asking versus kind of the direct response to legacy. But my question is, and I think it's more so from kind of the more, I'm going to use lay media coverage of Henrietta Lacks recently in terms of the movie or TV or whatever is going to take place. Has there been any difference in terms of the conversation and uptick of that, and what does that mean for investigators and the conversation taking place? And I'm just asking you because, again, I know your campaign was kind of dealing specifically with minority populations, but certainly, please, anyone respond.
I wouldn't be able to directly address if there was an uptick in the conversation because that's not something we directly track in my office. I wouldn't know the exact metrics around that conversation. But I will say we do have a partnership with Yale University, and we held a meeting, I think it was last year, and we actually had the family members from Henrietta Lacks come and talk at that meeting, just to talk about, what some of the issues were, how do we overcome, how do we move past those issues, and to really share their story and their perspective. And from my personal perspective, I thought it was very powerful because a lot of times you hear about it, you see about it, but to get that firsthand, account of something that has happened to a family member, I thought was very powerful.
Slightly tangential response to your question. What we found is what's happening with people with disabilities when they interact with clinicians right now is critically important to them, which is the way they sometimes feel stigmatized, they feel discriminated, they feel that they're not respected, they're not heard. So that has really, what we find, has more of a cumulative burden on their participation in research studies. I can't speak specifically of clinical trials, but I think that, so it's almost their current interactions with the healthcare system.
I just wanted to piggyback and really emphasize what Giovanni and Monica are saying, in that for us, really, diversity in clinical trials is important. And I really think, for me personally, transparency and authenticity is key. And so it just doesn't start with, we do all this work to get people enrolled into a clinical trial, but what happens afterwards? Are we sharing the study results with them? Are we getting feedback on what went well, what didn't? So those are the things that we know we're doing in our clinical research advisor in terms of not just at the beginning, but even in the end, are we sharing results in a way and a format? Because we also have to understand that people ingest or digest information differently or access information differently. First of all, is it easily accessible? Is it in a format that makes sense for our intended audience? So we have to keep shifting and knowing that not one size fits all, but it's really about authenticity and transparency to really rebuild trust, especially for minority communities.
Got a couple of more questions, and here's what a bottom line of what I heard y'all say. It's the trust is the relationship with somebody that's trustworthy, that's authentic, that's honest, and that they perceived has their best interest at heart, truly cares about them. So, Phyllis, is that you back there?
Here we go. Nicole, this is Phyllis Massey. So in direct response to you and to a topic that we haven't really talked about here is the enrolling of American Indians and Alaska Natives in clinical trials. There currently exists a moratorium against biospecimen collection that started with the Navajo Nation, went to the Cherokee Nation, and is essentially nationwide. And that is a real challenge because there are very few of us who are enrolled in clinical trials. And it doesn't matter how authentic you are, how trustworthy you are. Historically, the relationship with the federal government is a challenge. And it is, and the difficult part of this is that it has nothing anymore to do with that. We continue to have unethical researchers taking advantage of these very isolated, genetically unique people on reservations. How does that translate? For me in cancer, having grown up on the Navajo Reservation and having patients who live on the Navajo Reservation who have family histories that we know that they have a genetic predisposition to, for example, HNPCC. Can I offer them a clinical trial? No. Because the tribal sovereignty and the tribal government do not allow their people who are living on the reservation to participate in research. And so we're having a real, and that's why this this workshop now is so very, very important, because while we talk about transparency and authenticity, we still have areas, and it's not just American Indian, Alaska Native. It is rural people who in small church communities who have similar challenges, who don't trust. And we're not breaking that barrier, and we're leaving a whole population behind. And that's you ask the question, but are the people who matter, who make those decisions, listening and getting those and finding answers to that?
I'm blocking everybody.
See you.
There's just so much here that we're talking about that's important. We could spend a whole day on just this piece of it. But and to Phyllis's point, I think one of the things that could be done here is recommend that a communication plan has to be a part of protocol development. And I say that because, whoever's making the protocol rules needs to include that. It needs to also include communication skills training in our medical colleges and as continuing medical education. That includes a component about clinical trials. We need to help everyone who's dealing with medical issues understand that clinical trials are a natural part of our learning process to get better medicines and treatments out there. And I think it's time that just has to become part of what we do, whether or not they're involved in clinical trials at all. A healthcare provider that's not involved in clinical trials can do that. A community leader, an organization, can do that. So it's like a fundamental switch, and there are communication models that actually aren't that difficult to implement if we start to think about them that way and include them in the planning of the protocols. And maybe that gets to Becky's point as well, that if we're going to use that as the document, then that has to be in there.
I love that a communication plan is a part of the study and how are you going to communicate?
Yeah, and then that part is, either with this group or with the recommendations you make, not only just say there has to be a plan, because that's lobbing the ball over the fence again to the healthcare providers who have no resources and no time to figure out how to do that. So let's give them the tools or guidance along the way as well in how to incorporate that into their daily workflows so that it doesn't become an impediment and a burden to them to be able to care for their patients. There are also tools that are available. FDA right now has patient-focused drug development guidances that they're putting together. City has tools on how to communicate and work with patient advocacy groups. That's only one level of patient input, but it's an important level. So there are resources that are already out there that I think could be identified and collected by the roundtable that says, here's our recommendation and how we suggest to include at least components or a framework of how to implement this. Does that make sense?
Hi, Jay Dewig with the Roundtable. Playing off of what Deb just said, Dr. Williams, is there an opportunity for clinicaltrials.gov to make that a requirement or a recommendation? Because, well, I'm looking at two things on your history. First, the clinicaltrials.gov that's done, I would say, address publication bias in a very meaningful way by saying this needs to be opened up. And the work of the FDA's Office of Prescription Drug Promotion really led by example of 50, 60 people that wound up regulating and really having an impact on billions of dollars of drug advertising. So when things carry and have smart regulation and things like that make an impact, but would that be something, either a communication plan or requirement, something we've hit on multiple times today, a requirement for user testing of what's called patient-facing materials that would go along with and have to demonstrate with some degree of patient data. So whether comprehension testing, human factors, or whatever the usability testing might be, that would be part of a protocol submission. So I'd like to hear from you if that would work from a clinicaltrials.gov perspective, and then from the other panelists, if you think it would work on a practical level and make any difference.
Yeah, so I think from, where we sit, we're at kind of a strange place in that our mission is to represent the research that the researcher is doing. And so in terms of what we're able to influence in terms of that protocol document itself, we're kind of too late, in that process, and that people are coming to us once they've developed their protocol. But I think there's lots of opportunities to think about all of the different ways that we could incentivize some of these practices earlier so that by the time they come to us, it's in exactly that shape. And so, the most simple example is there's a lot of focus on, creating protocol documents that can, just be electronically transferred, and all the elements that you need for registration will pop up on clinicaltrials.gov, and you don't need a human, it's going to be great. Well, in order to achieve that particular goal, you have to ensure that the document at the start has all of the items that are necessary. And so there should be lots of reasons that people would want to do this, yet we still are a little ways away from that happening. So I think kind of, again, back to the question of the stakeholders, even though we don't love that word, that it is really a collective responsibility in terms of trying to figure this out. We can promote best practices that hopefully would then filter to us, but I think in terms of requirements, we're not going to be the ones to place those requirements.
This is Emma, and I guess just playing devil's advocate. I would argue that, the protocol is not really intended for all audiences. So maybe it's not the protocol that should be the end-all be-all, because maybe the protocol is written for the clinical investigator to be able to conduct the study, but should it be the same document that is then used to inform the public about the trial? So I mean, again, when we talk about health literacy, an intended audience, the way it's written for the investigator cannot then be written how can you then shift that to serve the purpose of the public? So I'm not sure that's maybe we need to have a different document for clinicaltrials.gov, because a protocol is written about how a study is going to be conducted, and the intended audience is a clinical research team. We would expect a participant to really understand all the jargon that goes into the protocol. So I mean, I'm not sure.
I think that's a key question, though, is how much jargon is necessary in different aspects of the protocol, and what are all the needs of the entire team using that document. It's just not the physician using that document. You have a whole team that's responsible for understanding it as well. So I think, unfortunately, that's the way the protocol document is being used today, is the dissemination vehicle. But I think it is important to think about how are we really going to meet those needs.
But I'd argue, is that the right one? That's all. But I mean, I hear you.
I don't know. Yeah.
Trying to make it fit for all audiences, I don't think is the right approach either.
So, Melissa, are we 2 minutes over, or do we have 2 minutes to go? I don't know.
You were 3 minutes under. So
Or what, say again?
you have 3 minutes.
Okay, please get a question.
I have a question.
Oh, can we open it up? Yeah. Yes.
Oh, hi. Thanks. Steve Rush, Roundtable member. About 3 or 4 years ago, the United Health Foundation had a grant program. And in the grant proposal, they had a section on dealing with health literacy and how you're going to communicate the results of your project out. So I think that there's some precedent, if you will, for doing something like you were talking about. One of the things that we also had done was to take some of our patient-focused communications, and we did it, we had 2 different models. One was a standard model of patient or member communication, and then there was a revised health literacy related model. And it was interesting. We did focus groups in 3 different areas. And what we found was that the people who looked at the redesigned health literate model said, this is an organization that cares for me. This is an organization in which I would have trust. And so if we're looking to develop a case for enhancing our communications, there's some really good research out there. And it's certainly not only within United Health Group, but also within other organizations too. Thank you.
I had a similar experience at the NIH. I'm Barb Biesecker from RTI International, but I was at the NIH Intramural Program for 25 years, and we did a very similar study with a low literacy simplified consent versus standard of care in genomics. And they were equivalent in terms of a variety of different outcomes, but were much appreciated in the same ways that people were thinking about them. And it was an embedded study in a large cohort genome sequencing study, so it was a layered study. I collaborated with the investigator who was interested in looking at genes that contributed to a particular condition, and he didn't want to do consent because it was burdensome, so I said, I'll do a randomized controlled trial and do consent, which the IRB approved. But the larger study, I said, if I do this consent study, we also need to embed a responsibility to report back to your cohort what you're finding in your study. And he said, I would love to do that. So we made a commitment every year to give the cohort an update on what was happening in the genome sequencing study. And because we had the simplified language, which we worked on, I'm sure Dr. Rush did too, for a very long time with stakeholder development, we had simplified language about how to talk about genome sequencing. So once a year during, probably lasted 5 to 8 years, once a year, we would sit down and write a summary of what had happened in the overall cohort, what we were learning. At the beginning, it was just like, there's some promising genes, but we don't know if they're related to the disease yet. And then it got more specific. And we got lots of follow-up questions by email. I just sent it as a blind CC email. There's nothing complicated about this. It took me probably a day a year in order to communicate back to the cohort what was going on in the sequence study. So I have a really hard time being empathetic to the fact that it's hard to do this. I wasn't the PI, but all teams have people who are trained in communication, at least somebody is, and can communicate that information back to people.